Hello, I'm Chris Marcus, a pharmacy intern from Pacific University School of Pharmacy, and I am working with my preceptor, Dr. Merlot, to prepare a drug class monograph on the familiar hypercholesterolemia drugs. So there are 3 drugs that are under consideration, and one of our current formulary agents is ezetimibe, which inhibits cholesterol in the small intestine. We also have 2 MAB drugs, PCSK9 inhibitors, that are also being considered, one of which is Formulary and one is newly being considered for Formulary. Evolocumab is already on Formulary, and alirocumab is the one that is being considered for Formulary. And if you refer to your one-page executive summary, you can see descriptions of the products there. But in short summary, the ezetimibe is an oral tablet, and the 2 MAB drugs are actually injectables given by the subcutaneous route. All 3 of the agents are FDA approved for primary hyperlipidemia, and they are also used in patients with familial hypercholesterolemia, which is in particular difficult to treat or to get patients to their LDL goal. And these patients have a very high risk of cardiovascular events. These agents are included in the cholesterol guidelines and basically in the role of for patients that are not able to tolerate or are not able to get the significant reduction in LDL desired, then these drugs may be used, and no particular agent is preferred over the others. The PCSK9 inhibitor MAB drugs, they work by increasing basically the number of LDL receptors that are available in the liver to clear the LDL from the blood, obviously, which would lower the LDL cholesterol level. And there have been some head-to-head trials of all 3 drugs, and also some head-to-head trials of the PCSK9 inhibitors. In clinical trials, both of the PCSK9 inhibitors have been shown to significantly be more effective at lowering LDL cholesterol levels compared to placebo, or also compared to placebo and ezetimibe. And among those PCSK9 inhibitors, evolocumab has a greater LDL reduction than alirocumab. And there's stronger evidence, though, that evolocumab is more effective than alirocumab in patients with familial hypercholesterolemia if they have varied cardiovascular risk and if they're not yet at their target LDL. But there is also stronger evidence that alirocumab is more effective than the evolocumab in these high CV risk patients who are not at target. So it does appear that there may be a unique role for each of them. Neither of them has been studied very long term, and thus we don't have a complete picture of their health effects, both benefits and risks. The main adverse effect of concern with the MABs is injection site reaction, and of course hypersensitivity reaction, and some myopathy has also been noted. For the ezetimibe, the main adverse events noted are joint pain, diarrhea, and some fatigue. Overall, though, all 3 drugs are fairly well tolerated. Laboratory monitoring needs of all 3 drugs are similar. Patients may prefer to take the ezetimibe tablet instead of getting an injection, but the injections are actually infrequent, usually twice or just once monthly, and that might improve the treatment adherence over having to take something daily. One of the downsides of the MABs are that they are more expensive, about $1,000 per month compared to ezetimibe, although the cost between the 2 MABs is not that dissimilar. However, they do reduce the LDL to a larger percent than ezetimibe does, so perhaps in the long run they actually are more cost effective. At this time, alirocumab is only being considered for familial hypercholesterolemia, but I think there is a chance that in the future either of the PCSK9 inhibitors might be added for statin therapy in patients who don't necessarily have familial type, but have stable CVD and still have LDL cholesterol levels that are above goal. And I can see that perhaps use might be expanded in the future to help prevent future CVD events in those patients as well. So in summary, both evolocumab and alirocumab both show evidence for significant reduction of LDL cholesterol in comparison to ezetimibe, and thus equally should be recommended for formulary status because there might be unique situations for different patients that would favor one over the other. So at this time, my recommendation is a step therapy approach, and I would suggest that all three of these agents would be started after a patient has tried and failed or not achieved sufficient LDL reduction with a statin. So I recommend that ezetimibe remain on formulary at tier status 2, evolocumab remain on formulary at tier status 3, and have a PA applied to it that would be reevaluated every 6 months of therapy to make sure the patient is responding and not having any adverse events. And likewise, alirocumab added to formulary also at tier 3, again with the same PA restrictions as the other mAb. Thank you, and I'd be happy to take your questions now.